Okay, so Steve just covered the most important variable in PD file. In order to study medication utilization, you need to identify the drug, and that's in the product service ID. So I'm going to building on that. I'm going to discuss a little bit more on how we can actually link or use these PDE variables for our research that we anything that we study regarding drug utilization. So the 3 points that I'm going to cover, the first one is PDE variables that we need to construct medication utilization variables. And I'm going to briefly cover this one derived variable benefit phase. And then we're going to actually discuss the measures of medication utilization we can construct, create using PDE records. And I'm going to focus on two most commonly used measures, MPR, medication position ratio, and PDC, proportion of days covered. And we're going to do some exercise as well. So the first thing, okay, so you're going to study medication utilization, and that's why you want to use Part D data. So what do you need to first decide? So what drug you're going to study, right? So then that information is in, why it doesn't work? Hold on. Give me a second, it doesn't work. All right, so that information, you have to first decide what drug you are interested in. That's in the product service ID, which we just looked at, and this is NDC information. And also there are variables associated with this NDC, which is brand name and generic name, and you need to spell correctly the way PDE data record. Now, again, Steve just covered this. If you are interested in examining therapeutic class of anti-diabetics or antihypertensive or statins, then you need to identify all indices of a therapeutic class of your interest. Now, yes, RX norm is probably, I see people are increasingly use this RX norm because it's somewhat free. I've been using a little bit more proprietary database of MedSpan, and there are other database are first data bank or Multum, and these database list therapeutic class and disease. And actually they have a lot more informations, including indications or all the histories or prices and etc. And you can, if you use this database, you can link this database to PDE based on the NDC or product service ID. Right. So next, what information do you need? So let's suppose you're going to study something, Medicare beneficiaries, you know, what do you need to know? The first one is a drug. So I decided to study hepatitis C drugs. Fine. And then any other information that you need to study medication utilization. So if you think about any medical service you use, you usually want to know, we sometimes are interested in when they receive the service and or what kind of service is actually in the drug name, but then how many times and etc. So in drug research, we usually count this prescription amount based on days. So another key variable that you want to know is prescription days days of supply number that contains how many days the beneficiaries filled up their drugs. Now, and then the another key variable here is prescription service date, which is a service date, the variable name. And this tells you about the prescription fill date. I have to be very careful. This says initially initiation date, but it's essentially fill date. We never know. That's the date that beneficiaries picked up the drugs at pharmacy, but we don't know when they actually start taking medication, which we will not be able to know when we using secondary data sets, right? So this is the distribution of this prescription days supply variable. You can see here median is 30 days, which means that usually beneficiaries actually fill the prescription for probably monthly basis. And interestingly, mode is 90 days. It used to be actually 30 days as well in earlier years, and this is my first time to see 90 days using 2021 data. And this means that 90 days are usually for the mail order. So they fill up 3 months of supply using mail order. Why mail order? It's a little bit cheaper and less expensive than filling the prescription at pharmacy on a monthly basis. And that's why I think it's an increase in mail order. The filling is increasing now. And then another thing to note here is that you might actually see some records that has value of 0 in prescription data spread. These are very, very small number of cases. So it's your discretion what to do with this record. I would easily drop this because it is a so small number of medications. But what does it mean that data supply is 0? Does this mean that the beneficiary filled the prescription or not filled the prescription? The beneficiary didn't keep any drug, any pill, right? So it might be typo or what is it? So it's really hard to know just looking at PDE records. And when it's a very small sort of percentage, you can exclude. But this is again researchers' discretion, and you may want to actually look into some abnormal or unusual cases and to see what happens there, and then you make decisions. So bottom line, it's really simple. Here, if you just need to remember 3 variables and make sure that you request these variables. PDE data request is really minimum necessary. You have to justify what variables you need. Make sure that you actually check these 3 variables, and these are key variables you need: product service ID and service date and days supplied. Now, next I'm going to discuss this benefit phase variable. And this is, we've been calling this as a derived variables. What does this mean? So this means that this was not originally recorded at pharmacy. Rather, this was constructed by CCW. When they process CMS data for researchers, they looked into each beneficiary's plan benefit scheme and also how much that beneficiaries has been using up to that point. So to accumulate the drug spending. And then they try to come up with, this specific drug event, drug field, actually belongs to that benefit phase. So this has this is a 2-digit variable. And why 2-digit? Why we cannot identify with a single digit? This is because it does not have slide 9. Oh yeah, it does not. I just added it just to summarize this. Yes, it's just only 3 variables which covered previously. So the question, I'm sorry, the question was that what is this? It's not included in package. Yes, it's not included in package. I just added in the morning just to summarize what I covered so far. All right. Okay. So now, why this benefit phase variable is 2 digits? Because that specific event may straddle more than one benefit phase, which means that when you actually visit the pharmacy and you were in deductible phase, but that drug you're going to feel was so expensive, and you may actually, because of that drug event, you may actually hit the catastrophic coverage. So the first digit represents the benefit phase at the start of a prescription fill, and the second digit represents benefit phase once the pharmacy dispenses the drug, right? So we've seen this diagram before. Steve covered a little bit in the earlier segments. Now, this is original really when the Part D program was first created in 2006, and this is a really original standard of benefits. I want to show this. We still want to actually, we know that now the coverage gap has been closed. However, we still use this benefit phase based on this standard diagram. And there is also specific and or official term that this PDE data or CCW uses in order to indicate a benefit phase. So this coverage gap, which we know as a gap or donut hole, this is official term is ICL, which is initial coverage limit. In other words, once you hit this initial coverage limit, it's on your own. That's how the Part D program started. And then, so in this, in the middle, the Part D benefit begins with a deductible, and then there is ICL coverage gap, and in between, we call this one as a pre-ICL. This is pre-ICL benefit coverage. And then once you actually pass through this coverage gap, you hit catastrophic coverage. So the benefit phase variable actually follows this name, and which you will see. Now, what okay, we know that. So, okay, we started with this way. However, now donut hole or coverage gap has been closed. And this is also just Steve showed that this one. This is a 2022 benefit, and this is a 2023 benefit. No change. Now, beneficiaries, their co-insurance rate, cost sharing is the same, whether you are in the this initial coverage limit phase or pre-ICL phase, it's just a 25%. But then why do we try to distinguish this benefit phase? Because who pays the rest differs, right? So if you so deductible is all on patient and beneficiary. Pre-ICL, initial coverage during the initial coverage period, patient pays 25% of co-insurance. Now, the rest of 75% who pays Part D plan. We usually say that, oh, this 75% is covered by Part D plans, but also I want to a little bit remind you or careful that this Part D program is a publicly financed program, which means that this program is run by your tax money, right? So, and essentially when Part D plan pays, that's from government. Already CMS or Medicare gave money to Part D plans to cover these drugs. But just because for convenience, we say the Part D plans, but it's essentially coming from government financing. Now, once they hit the coverage gap or ICL, initial coverage limits, Part D plan pays only 5%, no change in beneficiary share, and the rest 70% if that is brand name drug, and 70% comes from manufacturer, right? So we want to, in our data, we want to actually specify, okay, who's paying how much? This is a beneficiary, and this is covered by manufacturer. You can tell actually from data, and this is what's covered by Part D plan. And then after that, you hit catastrophic coverage. This simply shows how actually donut has been closed over time, and it actually depends on it differs depending on whether it's a generic or brand name drugs. And for generic drugs, even the donut hole after donut hole closure, 75% is covered by Part D plan, as opposed to brand name. It's only 5% is covered by Part D plan, and 70% is from manufacturers. Now, so these are the values that you will see in the benefit phase variables. So I'm beginning with this DD. So if it's the benefit phase value is a DD, this means that you start with the deductible phase and then you end with deductible phase. And DC, what does this mean? So you begin with the deductible phase, but it's kind of really costly drugs, and you immediately hit catastrophic coverage. Then that has a value of a DC, right? And this is essentially donut hole or coverage gap. But because the official name is ICL, initial coverage limit, and it says II. And the IC is a straddle between ICL, donut hole, and or coverage gap, and catastrophic phases. So this is a distribution of this benefit phase variable. So a lot of drugs are in DD, deductible phase, and also PP. PP is a pre-ICL, where you have a 25% cost sharing before you hit the coverage gap. And then some come from II, and this is a coverage gap, right? Donut hole. When the donut hole is closed, you're still in the benefit phase of donut hole. Now, so when do we want to use the benefit phase variable? So specifically, you may want to I'm sorry, I was just looking at the question. I will actually look at the question later. So when do we want to use this benefit phase? First, you may be interested in, how many beneficiaries reach catastrophic coverage? And also you can ask this question and say, or before and after donut hole closure. right? So once the coverage gap is closed, now beneficiaries face much lower cost sharing. So they may be actually taking more medications, right? They don't feel that they are in the coverage gap and they keep taking their medications. And we can expect that, oh, there may be probably more beneficiaries are hitting catastrophic coverage after this benefit scheme changes. And also the, okay, catastrophic coverage by definition, the cost sharing on the patient side should be low. However, these days the drugs are really expensive. Then how much they actually pay out of pocket during this specific catastrophic coverage benefit phase. So in order to answer these questions, you may want to get, you have to select PDE records that has C in either first or second visit, right? And that tells you that they are in the catastrophic coverage phase. And also you can ask any questions like, oh, do beneficiaries change their medication use patterns once they hit the catastrophic coverage? Because their cost sharing got lower once they enter catastrophic coverage phase, then they want to actually fill more medications. And these are the questions that you could ask. And then that's when you want to use a benefit phase. Could you please clarify again, benefit phase? Let's go back. Just a quick question here, is clarification question, this catastrophic coverage phase. So this is when your troop or your true out-of-pocket spending reaches in 2023, $7,300, then you enter this catastrophic coverage. So this actually, and once you hit this phase, your cost sharing is only 5%. And if you are low income subsidy beneficiaries, you have only $5 or between $4 or $10 of co-payment. So this is really for those who are already spent a lot of money on drug use, more than $7,000. Once you enter this coverage phase, we try to minimize the patient cost sharing. And then this government pays not through Part D plans, but government directly actually pays 80% of the cost in this benefit phase. And then 15% is covered by Part D plans. Now, I know that because of this Inflation Reduction Act, IRA, which passed this year, last year, that we will have our pocket spending limit here. There will be another change in the coming years. But currently it's 5% co-insurance. Yes, so does the benefit phase reset every January 1st? Yes. Okay, so that's about our benefit phase. Then now we're going to move to this measures of medication utilization. How do we, I know some of you already have some experience with drug research, and does anyone want to share what measures you have constructed? So when we say that, oh, I'm interested in looking into Part D, prescription drug use, and what are you talking about when you said what measures specifically? How would you look at, how would you examine drug utilization? Anyone want to share? You can unmute if you want to chat, or you can leave any message, and I don't see any, so I'm going to move on. So the first thing you could think of is, oh, yeah, just the medication uptake. Do beneficiaries use any drug? But that's not really interesting, right? So when you use actually medication uptake, the uptake means it's 0 or 1, right? When you use or not use. And for these measures, is you may want to really specify population with a specific condition, right? So this is whether the beneficiary uses recommended medication or not. Among those who have a diabetes, do they take anti-diabetic drugs, right? Then this is medication uptake. So for this measure, you have to define population with a specific condition. That means that, oh, you need information about diagnosis or a patient condition. Do PDE data files include information on condition? Yes or no? Do we know from PDE data that whether this patient has diabetes or not? No, okay, no. Okay, I see many no's. Yes, no, it's purely we know that only what drugs they took. right? So then this means that in order to measure this, use this measure, you have to use Medicare Part A and B medical claims data, right? So you have to pre-select your study cohort. Now, second measure, so that's medication uptake. Now, this is an example we're going to actually look at in the Excel sheet in the exercise. Now, I'm going to introduce here the drug that I have studied for a while. So this is drug called Sovaldi, or this is really the first new and very innovative hepatitis C virus treatment. So it probably won't be an exaggeration when you say that this Sovaldi was really, with the Sovaldi, we entered this era or period of really high cost medications. So when this drug came out first in December 23 at 13, and this one pill cost $1,000. Which actually drawing a lot of attention of media or policymakers or researchers. But this drug was really innovative compared with the previous drugs or the conventional drugs, and these actually cure the virus. So once you take this drug for 12 weeks, just the one pill per day, which is a very convenient administration, you can actually kill the virus. So well, because of this innovative sort of nature, and that the manufacturer actually charged $1,000 per pill. Now, then first, as a researcher, the first thing to come to your comes to your mind is, oh, really? How many patients take the drug, right? This is super expensive, but it's super novel, and it's this high, really superior characteristics. I want to see take-up rates, right? So then you can ask, oh, what percent of HCV patient with a hepatitis C actually took this new innovative HCV drug, Sovaldi, right? So that's just one way to use your uptake measure, and we're going to look at this in the PDE data. Second, you can actually use medication adherence or medication non-adherence. I have to say again, I added this non in the morning because you can measure either way. So medication adherence, it measures extent to which beneficiaries takes, or if you're looking at non-adherence, does not take a prescribed medication according to a schedule, recommended schedule. Okay? So there are various measures that you can actually construct. You could focus on percent of the time with the RX at the prescription drug, or a percent of the time without RX. That this is going to be adherence, and this is going to be non-adherence. And you can also use, what time period? You can use a specified time period, or you can simply use the Part D data or any drug data and look into refill intervals. So NPR is one of the most commonly used measures of drug medication. This is medication possession ratio, and this focuses on proportion of days supplied. Again, emphasis on days supplied, right? It's different from days covered. And this is days supplied during a given time period. We will see the differences in the next slides. Right, so how do we measure NPR? So there are two ways we can measure NPR, and it depends on how we specify time period. So the first measure is you simply say that, well, my study period is this 1 year or 2 years or 60 days or 90 days. So you just specify your time period. And then that's going to be your denominator. Now, again, there are two ways of specify your time period. First one is just a fixed follow-up period. I know that I'm going to just see all the patient who has a diabetes on January 1st, 2020. And I'm going to follow these people up to December 31st, 2020. So my follow-up period is 1 year. So that's how you could actually specify your time period. That's one way. Another way to do is, well, you know what? I have only this 2020 data, and I'm going to actually, I don't know whether this beneficiary has diabetes on January 1st. So you could actually see that just only first the fill date. So I'm going to assume that from this date, maybe this patient was diagnosed with diabetes, or that was April 1st. So I'm going to follow up this person from April 1st to the end of 2022. That's the data that I have. So that's evaluation period. And then if you are using this one, your denominator will change by patient, right? So each patient has a different first field date that you observe in your data. So that's how you specify your time period. Anyway, you follow up to the end. And then in the numerator, during the specified period, you just sum up all these days supplied. Then it's the total RX days supplied during that specific time period. That's one way to calculate MPR. This is probably the most commonly used definition of an MPR. And then some people came up with this some a little modified MPR measure. And basically just change here denominator a little bit. Well, you know what? I know that I'm following up this patient for 1 year or from April 1st to the end of the year, but I observed that this patient suddenly discontinued their medication on August 1st. So August 1st is this patient last fill date. So I don't know what happened to this August 1st. So what I'm going to do is I'm going to simply look at the total number of days between the first and last fill dates. That's assuming that maybe the patients experience side effects or the doctor said that, oh, don't take it then. Then we want to be fair. So I want to limit my denominator as just during this first and last fill date. So if you define your denominator this way or time period this way, then in the numerator, you sum up all this data supplied, and then you subtract prescription data supplied from the last date, because that's, we don't want to care, because our in denominator, these days are not included, right? So you just subtract this number from total data supply, and that becomes another MPR measure. And I'm going to call it as MPR modified. Oh, does this matter? So let's look at this example. So this one is the follow-up period, or I define the specified period is for the first measure as 1 year from April 19th. This was the first diagnosis date of, let's say, diabetes. And then I'm going to follow up to April 18th, 2010. So, and then these are for this follow-up period, and this is the Part D record that I got. So this patient, the diagnosis on 19th, and then first fill date was April 27th, and this is days supply. So MPR first measure is really simple, right? So your denominator is already, you said that I'm following up this patient for 1 year. You fixed your time period. So 365 days is your denominator. And then you simply sum up these days of supply in your data. So there was 118 days, and you divided this 118 divided by 365 days, and that's your MPR measure. So one of the assumptions behind this measure is that, you know what, this, whether it's diabetes drugs or hypertension drugs or anti-hyperlipidemia, these requires really somewhat lifelong or long-term treatment. So you assume that they are supposed to take this on this medication for 1 year, right? Then you consider that the rest, this like September, October, November, the patient didn't fill the prescription as non-adherence, right? Discontinuation. So that's your MPR is a measure. It has a low value, which means that it has a really poor adherence, right? Poor medication adherence. Now, another way to think of, again, as I said, why? How do you know what happens on this, July 14th or August 20th, sometime here? The patient must have may have developed some contraindication, right? So that, because of this drug-drug interaction, you have to probably drop this medication or develop some other side effects. And the physician said, okay, you can just then actually temporarily, or you can just drop that medication. Then if that's what you believe, then you just count the denominator as the days of interval between the first and last days. So this is going to be some of these first four rows. This is going to be your denominator. And then you can actually sum up this days supplied and subtract this days supplied from the last days. Yeah, from the last one from the sum. Then your MPR, the modified MPR measure will become 0.9, right? So this make a huge difference, right? Okay, so now this is a brief explanation of MPR. Now, one issue that you really want to pay attention here is that there is issue of oversupply. What do you mean by oversupply? So oversupply is supply in excess of what is appropriate or required. And why does it happen? And what does this mean? So let's look at this example. So this one says, oh, okay, so this patient begin to fill this drug from June 19th. Oh, 21 days of a supply, fine. She came back or he came back on July 10th. Oh, okay, so it's really 21 days, right? So probably the beneficiary completed the treatment and came back and 35 days and then came back again and after 35 days. Now here on August 14th, this beneficiary filled only 21 days of a supply. But then the beneficiary didn't come back 21 days later. The beneficiary came back 30 days later. Oh, then we know that, oh, there was 9 days not covered. 9 days the beneficiary didn't have any medication. So move on. Let's continue. Here in October 13th, the beneficiary filled 35 days of supply. But then came back on November 13th, 30 days later. Now, if we are not really looking into record by record for each beneficiary in Part D data for 20 millions of your people in your data. So what happens here is that you're going to simply sum up this day's supply. Then during your calculation, these 5 pills that's left over from October was filled in here during the gap in early September. So early September, the beneficiary clearly didn't have any medication. However, because there was some left over here, it was filling up during this one. In reality, that cannot happen, right? So there is a possibility of overestimating drug adherence. So usually we don't know, but what you actually end up realizing this issue is that you have actually MPR, greater than 1. You may actually see, you calculate based on this, following this formula, this, oh, wow, this beneficiary has an MPR equals 2, MPR equals 4, MPR equals 1.3. What does that mean? Getting 200% of drugs? What does this mean? That's because we are simply counting days supplied, right? So well, that's not really fair. There cannot, this should not happen. So in order to compensate or address this limitation of an MPR measure, people came up with this PDC measure, proportion of days covered. Now, this is days covered. So when this measure, what this measure does is that when oversupply happens, they apply this oversupplied portion only prospectively, which means that these 5 pills left over in October cannot go back to this early September to fill in this non-adherence in early period. So what does this, if you see this graph, okay, so there are some gaps here, right, in early days, like in late May here. So there are some gaps. And then, oh, here comes oversupply, right? So this was about 30 days or 28 days of supply. And then this beneficiary came back early, right? So there is some left over here. So what this in the programming, right? So in your calculation, what this does is that you pushes the start date of this prescription that has an overlap period, pushes back to the end of this prescription, the drugs ends. So these oversupplied portion can apply only prospectively. This cannot fill in these gaps in the earlier period. And that's the concept. That's the concept of PDC, and you can download the program from online. I downloaded, it's just the Google PDC SAS code, or not static code, I downloaded SAS code, and then that actual program calculates this PDC, and that's a difference. And I can see that when I started this drug research probably 15 years ago, I used only NPR, but I can see increasingly people are using PDCs because of this. Right. So a couple of thoughts, final thoughts about this constructing or using medication utilization measures based on PDE data. Just to be aware of the limitations or what you're doing. We never measure consumption of medications. There is no way we can know whether beneficiary actually took the medication or not. We only know the beneficiary acquired, right? The medication, and then that's the field of prescription. But what happens on the beneficiary's home or in the real life, we just don't know. And also we cannot measure timing of taking medications. Some drugs are supposed to take when you wake up in the morning, some drugs you're supposed to take before you go to bed, but we cannot actually measure or examine that kind of nature of sort of medication adherence, right? And also we cannot know the condition for which the medication is prescribed. Maybe they fill the diabetes drugs for other reasons, not just to treat diabetes, right? But still, I see more advantages of using this PDE data. So, well, you could ask, okay, then how can you actually measure? These are the things that I'm really interested in. How actually whether they consume or not, the timing and etc. Then usually what you could do is doing survey, actually observe a patient, right? Follow up, and then count the bottles and how many drugs are left over at home, etc. But for those things, you can study only very small sample size. But here, using PDE data, we can actually get the national estimates. Yeah, national estimates, and also why is national estimates means that we have really, really large sample that it allows us to do subgroup analysis. And you can say, oh, what happens in the Asian group? Oh, what happens in the Black beneficiaries? Oh, what happens in the certain, the Indian natives and etc. So those are the really strength of using Medicare claims data in general, and also PDE data. And also we can, Medicare data, we can follow up beneficiaries really long term and survey how many times can you actually repeat, right? So now we have accumulated this 10 years or 20 years of data. You can actually track that how it's the medication adherence or people's behavior in terms of taking medications actually changes over time. So these are really, I think it's a very strong strength of PDE data or Medicare claims data in general.